Hello, I hope you guys are doing well. Today we are going to talk about resistance exercises. So resistance exercises, it's any activity where dynamic or static muscle contraction is resisted by an outside force that is applied. So the key elements in resistance training are strength, power, and endurance. These are words you're probably familiar with, but the difference between strength and power, strength is just the force that's produced by the muscle. Power has a time component, so it's the force that is produced over a unit time. So force times distance over time equals power. That's kind of the math equation to figure out power. With high intensity exercise performed quickly, that leads to greater power. So the speed of the movement is involved in power. That's why powerlifting, they do it at a quicker pace than with just regular resistance training. Endurance is the ability to perform a repetitive or sustained activity over a prolonged period of time. So if you see in the picture, it's a swimmer over time going long distances. That is an endurance activity. You use low intensity, high repetitions in order to build endurance. This minimizes the potential harmful joint reactions and the forces at the joint. It produces less irritation to the soft tissues and is more comfortable for the patients. Overload principle. In order to build muscle, in order to increase strength or increase power, you must challenge the level of performance. So you must have the muscle perform something that it's not used to performing. And the things that go into that are intensity and volume. So intensity is the amount of external resistance imposed on a muscle, whereas volumes is the repetitions, the sets, and the frequency that you are imposing. So if you're wanting to build stronger muscles, you need to do something you're not used to, a greater force, greater intensity, greater volume than you're used to in order to strengthen that. With strength training, the amount of resistance is incrementally and progressively increased. So slowly over time, you're adding on until you get to where you want to be. It's not a big leap. It's a slow progression. With endurance training, we typically progress time or distance or the number of repetitions in order to increase endurance. If you see me keep looking, the camera is blocking part of the PowerPoint for me, so I keep having to look behind the camera in order to see the words, just so you know. The SAID principle, specific adaptation to impose demand. That's what SAID stands for, specific adaptation to impose demand. So if you're wanting to improve a specific muscle performance element, then your resistance program should match the constructs of that element. So for example, if you are wanting to increase your bicep strength, you must flex the elbow repetitively in order to increase your bicep strength. And the SAID principle, it is a guiding principle for therapists to determine what exercises are most appropriate and what parameters in order to meet the patient's functional goals. So if they're wanting to load and carry wood or boxes or something like that, then bicep strengthening is great. If they're wanting to run long distances, this bicep strengthening is not going to do anything for them. So it's the rule of specificity. You need to practice the same motions, activities that you want to be able to improve functionally in order for those to improve. If you are constantly doing high intensity quick movements in order to get better at an endurance activity, it's not going to help. So just because you're a good football player, this was my husband when we met, he was a good football player, but he came and took one of my cycling classes and was struggling, whether he admits it or not, because he was used to a whole different set of movements and type of activity. And then cross training, I really highly recommend for athletes to cross train, especially young athletes. So if they're a football player, they really do not need to be playing football all year round. They don't need to be on these travel teams and these spring ball teams and all these different teams that have them playing the same sport, doing the same movements 3 different seasons. Ideally, they would play 3 different sports so that they kind of give certain muscle groups rest, do different movements, and that will decrease their likelihood of getting injured or having the overuse injuries that you see with athletes that are year-round. Muscle fatigue, so that is the diminished response of a muscle to repeated stimuli. The things that cause it, one is disturbances in contractile mechanism. Things that cause these disturbances are decrease in energy stores that are available to feed the muscle, a reduced sensitivity and availability of intracellular calcium, and a buildup of hydrogen ions. All of those decrease the muscle's ability to contract. Other things that cause muscle fatigue are reduced excitability at the neuromuscular junction. Remember, you have to have certain components available in order to have an action potential, which allows you to have a muscle contraction. So reduced excitability on that level. And then an inhibitory or protective influence from the central nervous system. Over time, it starts to send a signal saying, okay, we keep doing this, we're going to get hurt. And then the brain will send a signal to calm down a little bit, and that will produce muscle fatigue as well. The types of fibers fatigue at different times. So type 1 fiber, that's your tonic or your slow twitch muscle fibers. These are engaged when you're doing aerobic exercises, and they are resistant to fatigue. This is what you use when you're a marathon runner or you're doing, long distance anything. Versus type 2 fibers are your phasic fast twitch. They're aerobic and anaerobic. So they're type 2A and type 2B, which are different based on what functions they have and which systems they're most active in. But these fatigue easily. They give you kind of high impact, quick spurts of energy, but they fatigue easily. And the type 1 take a little bit longer to warm up, but they're resistant to fatigue. They take a lot longer to get tired. Signs of muscle fatigue: discomfort, pain, cramping, shaking or trembling, slower muscle contractions, jerky or inconsistent movements, unable to complete a full range of motion, use of compensatory muscles, inability to continue low-intensity activities, and decline in peak torque. Now, peak torque, you find that with isokinetic testing. So it's not something you would just look at and observe, from a distance. But the other things, most of those you can see when observing a patient. So watch a patient. If they start shaking and trembling and having jerky movements or cramp while they're doing an activity, they probably have done enough of that activity and need to move on to something else, or at least rest before they do anything else. Cardiopulmonary fatigue. This is fatigue as it relates to the body's ability to use oxygen. So it is caused by a decrease in your blood sugar, in your glycogen, and in your potassium that is within the cells in the bloodstream. People with cardiac issues, peripheral vascular disease, or pulmonary disease, and also people who are undergoing certain medical treatments, such as like chemotherapy, fatigue more easily, and they require increased recovery periods. So make sure you read the chart thoroughly, know what comorbidities a patient has to see, what signs you need to watch for and how long to expect them to need to rest in between exercises in order to recover. With recovery, oxygen and energy stores typically replenish quickly within like 3 to 4 minutes of your recovery, versus lactic acid takes a little bit longer. It takes usually about an hour of rest before it starts to leave the bloodstream. Glycogen stores, those are stores of usable energy within our tissues. Those are used up when we exercise, and it typically takes several days to completely replace glycogen stores. If you have an active recovery where you're doing light exercise during your recovery periods, you recover more quickly, versus a passive recovery, just completely resting. It's less effective and you take longer to recover than in an active recovery. So even if you do a little too much, take a walk or do some light exercise, and it can help push more of the lactic acid out more quickly. It can also help you recover at a cellular level more quickly and decrease your soreness. I put a picture up here of this resting position. You see a lot of track athletes run as fast as they can and then stop and bend over, and that is not the ideal position. I think the longer things go on, the more I see people walking after they run rather than just stopping and bending over, which is a much better recovery position. Muscle changes with age. Of course, you know, these are my boys up top, my nephew too. During childhood or in pre-adolescence, we're talking about before somebody goes through puberty, muscle strength and endurance both increase linearly with age in boys and girls. So you don't see a big distinguish between boys and girls on muscle strength before puberty. The total number of muscle fibers is typically determined by birth or early infancy. That's one reason I put my boys up here. I have 4 boys, same mama and daddy, and they all have different body types and based on genetics, just what they were born with. One is a little bit more muscular, one is a little bit more thick, one is a little bit more thin, and the 4th one, who knows what he is yet. Just playing. But they all have different body types, even though they have the same genetics, because just based on how their muscle fiber types and how they were born. And even though they eat similarly and do the same activities, their bodies look different based on how they were made. Type 1 and 2 fibers are typically relatively set by age 1. And be cautious doing resistance training with somebody who is still growing, period. Some of the research shows that resistance training, so if you do some training like with body weight, like sport-specific drills and things like that, that's typically okay if you're just using their body weight. But when you're using true resistance, it puts a lot of tension on the tendons and ligaments as they're growing, and it can actually stunt their growth. It can kind of damage the growth plate, the epiphyseal plate, and cause stunted growth. So you really want to caution against doing resistance training until somebody has at least went through puberty. Ideally, they've went through puberty before they start any resistance training or started puberty. All right, more changes with age. So once you reach adolescence, strength increases rapidly. Males from age 10 to 16 increase their strength by 30% every year. I can't read today. Most muscles growth stops by the age of 18, but strength can continue to increase, especially in males, up into your 20s and 30s. So although muscle growth in itself may be plateauing, muscle strength can continue to grow typically until your 20s or 30s. During puberty, results from resistance training are 30 to 40% above those throughout normal growth and development. I'm sure you all can think of somebody you went to high school with that was kind of short, kind of scrawny, and then there was this summer that they just blew up and got tall or thick and came back looking like a man instead of a little boy before the summer. And that's because your strength and your muscle growth and development increase drastically when you're going through puberty. Muscle changes with age. So in your 20s and 30s, strength typically peaks in the age 20s for women and by age 30 for men. And then once its strength peaks, it begins to decline. Wah, wah, wah. So usually about 1% every year until age 50. But if you are active, the decline in your muscle strength occurs at a much slower rate. And the potential for improving muscle performance with resistance training is still high in this age group, 20s and 30s. You're still able to do exercises and improve your fitness level. You have really a high ability to change at this point. versus once you get to age 60 and above, the rate of muscle decline begins to decrease by 15 to 20% per decade. So that's still like 1.5%, 2% per year. And in those who are 80 and above, it decreases by 30% per decade, or up to like 3% per year. So the bad thing is, if you are sedentary during this time, you're going to see drastic changes in your muscle loss, atrophy, and things like that. But if you are still maintaining a high level of activity, you can decrease this by a great amount. So typically as low as 0.3% per year if you remain physically active. And loss in leg and trunk strength is associated with deterioration in function and falls. So the weaker someone gets over time with age, the more likely they are to fall, and the less independent they are with functional mobility. The other thing is power typically has a greater effect on balance and fall risk than strength. So sometimes people will have the strength to catch themselves, but not the speed. Remember, power has a time component. They don't have the speed. They start to lean over, and they don't have the speed to quickly move their leg to catch themselves. And so that can lead to falls as well. And power has more detrimental effects on function than just loss of strength in general. Okay, what causes muscle atrophy? Decreased number of type 1 and 2 muscle fibers, an increase in connective tissue within muscle. So remember, we talked about immobilization last lecture. When you're immobilized, when you're not using something, that the muscles become weaker and they are replaced with fatty tissue and fibrotic tissue or connective tissue. There's also a decrease in cross-sectional size of the muscle. Type 2 fibers actually typically will atrophy more with age. Change in length-tension relationship. And remember, when you have a change in your length-tension relationship, that affects your flexibility, your ability to move through your full range. There's a decline in motor units, a reduction in blood supply and in capillary density, decrease in mitochondrial density, changes in enzyme activity, and a decrease in glucose transport. And all those things will lead to muscle atrophy. Of course, this is kind of an extreme example. Most likely someone had some nerve compression in the nerve that feeds the gastroc, and they weren't able to use it at all, and so quickly the muscle atrophied greatly. And these changes in the muscle is what caused that atrophy. Effects of muscle decline. So muscle strength, speed of contraction, endurance, and ability to recover all decline with age. As the rate of movement declines, the ability to generate muscle power for activities that require quick responses, like making balance adjustments to avoid falls, also declines. So remember, I talked about earlier, a decline in power has a greater effect on function than a decline in just muscle strength. So even if you have the strength to catch yourself, if you don't have the speed, you're still going to fall. So power activities can be helpful as well when working with people who have balance deficits. Hypertrophy, so kind of the opposite of atrophy. Now the muscle's getting bigger. This is the increase in size of individual muscle fibers, which is caused by an increase in myofibrillar volume. So if you have one muscle fiber, myofibrillar, one muscle fiber, and the volume increases, the size of each individual fiber increases. And as this shows, there is a fusion of cells that come into the muscle, and that causes the hypertrophy to happen. Now, a muscle that's hypertrophied, if they stop training, will go back to its prior size. However, it will still continue to remain to keep more cells within it. And so then when you start training again, it will hypertrophy more easily than an untrained muscle. So it will react to that training more quickly. Hypertrophy is one of the main contributors to increased muscle strength. And if you are doing moderate to high intensity resistance training, typically strength will improve and you'll begin to see gains within 4 to 8 weeks. So moderate to high intensity resistance training, you're going to see some improvements within the first month or two. Muscle hypertrophy is primarily related to an increase in protein. We're talking about actin and myosin. Remember, those are what allow muscle contractions to occur. And so an increase in protein synthesis and a decrease in protein deterioration. So more are being made, less are being destroyed. And those lead to muscle hypertrophy. And then a high volume of moderate intensity resistance exercises increases hypertrophy the most. So not just a little bit of really, really intense exercise, but a lot of moderately intense exercise. And type 2B fibers demonstrate the largest increase in size. And so remember, those are the ones responsible for anaerobic activities. Let me pull up. Where was that earlier with type 2A and B? Right there. Type 2B are responsible for anaerobic. They're fast twitch. And so quick spurts of energy are what you want to do to increase those types of fibers. So powerlifting, things like that. Adaptation. So with high intensity resistance training, capillary bed density decreases due to an increase in the number of myofilaments per fiber. So essentially, the capillary bed density really doesn't change that much, may get a little bit less, but the myofilaments per fiber increases, and that means there's less capillaries available per muscle fiber. So as the muscle fibers, the myofilaments increase and get larger, the capillary beds don't increase to match that volume, and so then there's a relative decrease in the capillaries available to feed that. Versus like with aerobic exercise, capillary bed density increases. With anaerobic, when you're doing high intensity resistance training, they do not increase, and they have a relative decrease based on the number of myofilaments per fiber increasing, yet the capillary bed's not increasing. So if you're looking at endurance versus resistant, the opposite things go on. With endurance training, it's aerobic, capillary beds increase. With resistance training, it's anaerobic, and the amount of capillary beds available per myofilament decrease because myofilaments increase. Let me know if you have questions about that. Changes with muscle adaptation, more changes. So type 1 fibers have been found to convert to type 2 fibers. If you stop doing a lot of endurance training and start really focusing on powerlifting or something like that, then we see changes from type 1 to type 2 fibers. But if you do the reverse order, there's not really any research to support fibers changing from type 2 to type 1. So you basically have all the type 1 fibers you're going to get. You can either strengthen them or not. But if you really push yourself in powerlifting and resistance training, short duration anaerobic exercises, you can increase the conversion of type 1 fibers to type 2. As we work out, our tendons and our ligaments get stronger. We also get more connective tissue within the muscle because that gives larger muscles more support. So if we don't work out, we get more connective tissue in the muscle because it's replacing the muscle fibers. If we do work out, we get more connective tissue in the muscle because it's giving more support to a larger muscle. So both of them increase connective tissue. Bone density increases as we work out, and this reduces the risk of fractures and age-related bone loss. One of the best things to do to increase bone density is weight-bearing activities. That's why I have a picture of them crawling. When you weight bear through your arms and legs, that's just a great thing to do to stimulate the reabsorption of calcium within the bones, which stimulates an increase in bone density. However, most of the time it takes consistent exercise resistance training for 9 to 12 months before bone density really has a significant improvement. So if somebody's coming in with osteoporosis and they're wanting to increase their bone density, they need to look at a long-term solution, not a quick fix. Determinants of resistance training. So we need to look at the alignment and the stabilization. So we look at the muscle activity. What does it do? Which way are the fibers aligned? What does gravity do? How does it affect it? And what position should we be exercising in to target this muscle? Then with intensity, we need to look at their maximum load and try and keep the patient working in a submaximal load within the training zone. And in a couple of slides, we'll talk about the training zone and how to kind of target that zone. We can look at your initial exercise load and progress from there. With frequency, we want to determine, what is the best number of times per week to see the patient and for our specific goals. With volume, we're talking about repetitions, sets, and whether we're trying to go for strength or for endurance, which would determine how many reps and sets that we recommend them do. With our exercise order, typically we start out with larger muscle groups and 2 joint muscles, and then we go down to more specific, smaller muscle groups. We also typically we warm up, and then we start out with kind of high intensity movements, and then go to more low intensity, more specific resistance exercises. With duration, that's just the amount of time doing something, and that can be determined based on the fitness level and the goals of the patient. With a rest interval, just determining how much rest is needed, reiterating the importance of rest. If you're starting a training program, you do not need to just go in full force and do it every day without rest days. You will overwork and end up injuring yourself. So rest is key, and teaching the patient about active rest and passive rest. And remember, as we learned earlier, that active rest is kind of the main way to increase recovery speed and effectiveness. So passive rest is not as ideal. And then the mode of exercise, which we will cover in the next slide, exercise velocity. So a force velocity relationship. When you're working on improving power, you want to see, how much weight can we do, but how fast can we do it? How fast can we do this movement? And just kind of adding a speed component to that. Periodization and variation of training, seeing how much time do I need to spend on each thing and how can I change it in order to target the right things that I'm trying to target. And then integration of function. You want to find a balance between their stability and mobility, a balance between strength, power, and endurance. What does this person need to improve their function the most, to target exactly what they need to do to go back to their prior level of function, and let's make a balanced plan based on their needs. With the mode of exercise, we're looking at the type of contraction, whether it's isometric or isotonic or concentric or eccentric. We'll go over all that in a later slide. We're looking at whether they're weight-bearing or non-weight-bearing, what the form of resistance is, whether it's manual or mechanical. We'll go over that later as well. What energy system they're using. Are they using aerobic, which would increase their type 1 fibers, or anaerobic, which would increase their type 2 fibers? Anaerobic is more for building strength. Aerobic is more for building endurance. And then their movement range. Are they doing a short arc of movement or a full arc of movement? So going through their full range or just a shortened position. With the training zone, I talked about that earlier. The reps, so you find out what their 1 rep max is, and then you can go to the percentage listed in the chart based on that 1 rep max. So if you are doing 60% of the 1 rep max, so in the easiest example, if their 1 rep max is 100 pounds, then you would be doing 60 pounds. And when you are at 60%, the best recommendation for reps and sets is about 15 reps, 1 to 6 sets. At 75%, so if we were using that example, we'd be using 75 pounds, you would do 10 reps, 1 to 6 sets. And then at 90%, you're only doing 4 to 5 reps, 1 to 2 sets. So I remember my husband for a while was doing like the Arnold Schwarzenegger powerlifting workout or whatever, and he would start out with like 60% and do 15 reps, and then he would do like 70%, 12 reps, and then 80%, 10 reps, 90%, 5 reps, and then he would go backwards. And so you would build up to that and then build back, and that was kind of the recommended dose. And he'd be in the gym for hours working out, and it worked. It really increased his muscle size and fitness, and helped him reach fitness goals. The problem is keeping it up. If you don't use it, you lose it. Implementation. So with our patients, we typically want them to warm up, and then we determine the exact placement and direction the resistance needs to be, where to stabilize, the intensity of the exercise, how much resistance to use, how many reps and sets, how long a rest interval should be. We give them written instructions and provide them with a home exercise program so we know what they're doing in between. And then we always monitor throughout. So even if you come in, you have a whole exercise plan written out for them. If you watch them and after a few sets of the weight you decided they're starting to shake, well, either you need to go down in weight or down in reps, let them recover. And then at the end, we always cool down, and typically that will involve some stretching. With the well population, remember, as I told you in lab, with a sick population, typically we come in, we do more of the range of motion, stretching, joint mobs first to get our full range. Then we go through exercises, and then we cool down. Versus with a well population, you do some kind of ballistic, big movements to prepare for movement, do your exercises, and then stretch at the end in order to kind of increase your muscle length, but also decrease the lactic acid buildup. With a lot of our patients coming in with diagnosis, they don't work out at an intensity that's strong enough to really build up a big amount of lactic acid, so it's not as important to stretch at the end, but you want them to strengthen throughout their full range. So with them, we'll typically strengthen at stretch at the beginning before they go through their resistance training. Types of resistance training. So we have isometric versus dynamic, concentric versus eccentric, isotonic. All these are isokinetic, are coming on a future slide. PNF, open versus closed chain, manual versus mechanical, and constant versus variable. With isokinetic, I think that's the only one I don't have on another slide. That is a exercise with a constant speed or motion. So we talked about that in class, like if you're doing an exercise machine or something and you're going back and forth, like the elliptical might be an example of that. You're doing the same motion at the same speed over and over again. It's kind of a steady movement. Rowing could be an example of that too, if you're staying steady with your rowing. Isotonic versus isometric. So isotonic, the muscle contracts and changes length. Isometric, the muscle contracts, but the length doesn't change. So if I had my arm in this position, isometric is just making a muscle, just tightening that muscle. Isotonic would be bending and straightening. Concentric is the shortening of that muscle. Eccentric is the lengthening of the muscle. I have that on the next slide too. So concentric is shortening, eccentric is lengthening. With concentric, there is less delayed onset muscle soreness than eccentric, and typically a lot of people will kind of target a muscle by doing concentric, but eccentric in comparison to concentric actually provides more control of external loads, more gains in muscle mass and strength. The mode and velocity is going to be specific to the adaptation of the exercise, and then it also provides more efficient movements with less fatigue. So let's say you're doing bicep curls and you want to kind of focus on the eccentric lengthening of the muscle rather than the concentric shortening in order to build more muscle and have more control and efficient movement. then you could go up 1 and then down 2, 3, 4, up 1, down 2, 3, 4. So you've seen that in probably group fitness classes, things like that before, where they do it at different speeds, and that's to target either concentric or eccentric movements. So you can determine, what am I really doing with this? What do I want the benefit to be? And then that can help you decide whether you're focused on the concentric or eccentric. But eccentric helps you strengthen better, so ideally we would focus on that. That's another exercise I see pretty often that focuses on eccentric strengthening is retroambulation. I don't know if you've seen after an ACL surgery or something, sometimes they'll put the patient on the treadmill backwards and put like a TheraBand strap around them, so they're walking backwards but pushing into resistance, and that's eccentrically strengthening all the muscles that are needed to go through a normal gait cycle forward. So that's a great way of strengthening those muscles. Open chain versus closed chain. With open chain, you are in a non-weight bearing position and the distal segments are moving. The proximal segments are fixed and the distal segments are moving. The adjacent movements are unpredictable, but only the segments distal to the joint are moving because the proximal segments are fixed. So like, let's say the joint is the knee in this picture, then from the knee above, it's staying stable, it's not moving, only distal to the knee is moving. Only the prime mover is active and resistance is applied to the moving segment. So if you were wanting to apply resistance, you'd put a TheraBand or something around the ankle here, and that's the only place that resistance would be applied. It's very specific. It strengthens a specific muscle group, and it's a good starting place in strengthening. But closed chain is basically the opposite. The distal segment is fixed, so it's typically a weight-bearing position where you're standing on a surface. The adjacent movements are predictable, but all segments are moving. Distal and proximal segments are moving. So more segments are moving, multiple muscles are activated, and then resistance is applied to multiple segments at the same time. So if you're just wanting to target quadricep strengthening, you could sit and do long arc quads. If you're wanting to really strengthen all the muscles in the leg, then you could do squats. It's less specific, but it targets more muscles, and it is a predictable movement with the distal segment fixed in one position and everything above it moving. That is a closed chain exercise. Manual versus mechanical resistance. Manual resistance is applied by the therapist's hands. This is something we can control. We can control the direction and the amount of resistance throughout the whole movement, whereas mechanical resistance is applied by machine. The good thing about it is a constant amount of resistance throughout a selective controlled motion. So with manual, maybe you're only applying resistance at the end, or maybe you're changing the amount of resistance you're applying throughout the motion in order to meet the patient's need. With mechanical, it's a constant amount of resistance, but it's good because it's stable and it's controlled, and they only can do certain movements based on the way the machine is set. And then contraindications and precautions to resistance training. Contraindications include pain. This is, again, intense pain or pain that's significantly increased with the movement. Inflammation, severe cardiopulmonary disease, any of those, you would not do resistance training. Precautions. If a person does not know how to breathe while they're doing exercise, that would be a precaution. If they're doing the Valsalva maneuver, where they're basically holding their breath and exhaling against a closed glottis, that's the Valsalva, that can cause them to pass out. So you don't want that. If they're using substitute or compensatory motions, then you're not targeting the right muscle. I would not strengthen that. I would lose the weight and do a motion that they can control and target the right muscle. Overworking, overtraining, if they're showing any signs of that, lose the resistance. If they're having significant amount of soreness afterwards, especially delayed onset muscle soreness, more than 2 days after the exercise, or a decrease in their strength after the exercise, then you've done too much, you need to back off. If they have pathological fractures, like moving certain ways could cause a fracture, or there's bones that are brittle and pulling on them would cause a fracture, then you do not use resistance. Or if the intensity of the exercise is leading to pain. Now, if they were already in pain before and it's not increasing much, that's one thing. But if they weren't in any pain and then suddenly they're having sharp pains, that's a sign that it's damaging something and you want to avoid that exercise. All right, that is it for us for today. I will see you guys in lab. Let me know if you have questions.